Have you ever woken up in the middle of the night drenched in sweat, restless, or with an unexplainable urge to visit the bathroom? What if these aren't just random quirks of your body but silent screams signaling a deeper issue, like diabetes? In this video on Golden Years Health 2025, we're diving into 15 subtle nighttime symptoms that could be your body's way of waving a red flag about diabetes. These signs are not loud alarms but quiet ripples on the surface, hinting at a powerful undercurrent that could become a flood if ignored. Stay with us until the end to uncover every symptom, gain practical tips to take control, and learn how to transform your health before it's too late. Let's unravel the mysteries of your body's nighttime signals together. 15. Morning headaches. The painful dawn greeting. Morning headaches, caused by low blood sugar, sleep apnea, or dehydration, are worsened by frequent urination. Create an ideal sleep environment, stay hydrated, eat potassium and magnesium-rich foods, and consult a doctor for sleep studies if severe. Morning headaches in diabetes are a distressing wake-up call, often signaling overnight metabolic or respiratory stress. Hypoglycemia starves the brain of glucose, causing vascular constriction and pain. Sleep apnea, affecting up to 50% of diabetic patients, reduces cerebral oxygen, triggering headaches via hypoxia-induced inflammation. Dehydration, driven by nocturia, concentrates blood, increasing intracranial pressure. Electrolyte imbalances, particularly low potassium or magnesium, also contribute by disrupting neural and vascular function. In my research, I've seen morning headaches as a sentinel symptom, often preceding formal diagnoses of apnea or nephropathy. They are particularly common in patients with HbA1c above 7.5%, reflecting poor overnight glucose control. Chronic headaches also elevate stress hormones, worsening insulin resistance and perpetuating the cycle. Prevention requires a multi-pronged approach. Glucose stability is key. A CGM can detect nighttime lows, guiding pre-bedtime snacks, e.g., whole grain toast with avocado. For apnea, a sleep study is critical. PAP therapy can reduce headache frequency by 60 to 80%. Hydration is non-negotiable. Aim for 2 to 3 liters daily, but reduce evening intake to minimize nocturia. Electrolyte-rich foods, bananas, spinach, almonds, support neural health, while avoiding alcohol or sedatives prevents respiratory depression. Sleep hygiene is paramount. A cool, 16 to 18 degrees Celsius, dark, and quiet bedroom promotes restful sleep, reducing headache triggers. A supportive pillow and mattress align the neck, preventing tension headaches. Stress reduction through mindfulness or gentle yoga lowers cortisol, easing vascular strain. If headaches persist, a neurologist can assess for migraine or cluster headache mimics, while blood tests check electrolytes and kidney function. Over-the-counter analgesics, ibuprofen, acetaminophen, provide temporary relief but avoid overuse to prevent rebound headaches. Addressing glucose, apnea, and hydration typically resolves morning headaches, restoring pain-free mornings. 14. Teeth grinding, bruxism, the nightly creak. Bruxism, triggered by low blood sugar or autonomic neuropathy, causes jaw pain or headaches. Relax before bed, deep breathing, meditation. Use a night guard, and consult a dentist for persistent issues. Bruxism, the involuntary grinding or clenching of teeth during sleep, is a lesser-known diabetes symptom but a significant one. Hypoglycemia triggers adrenaline, tensing jaw muscles and prompting grinding. Autonomic neuropathy, affecting up to 20% of diabetic patients, disrupts cranial nerve function, increasing jaw muscle hyperactivity. Stress, amplified by diabetes-related anxiety, also plays a role, as cortisol heightens muscle tone. In my clinical experience, bruxism often goes unnoticed until patients report jaw soreness, chipped teeth, or morning headaches. Left untreated, it can lead to temporomandibular joint, TMJ, disorders, tooth fractures, or chronic pain. Diabetic patients are particularly vulnerable due to neuropathy's impact on muscle control and glucose swings' effect on stress hormones. Prevention starts with glucose stability. A CGM can prevent nighttime lows, while a balanced pre-bedtime snack, e.g., cottage cheese with berries, maintains glucose. Stress management is critical. 10 minutes of progressive muscle relaxation or a warm compress on the jaw can reduce tension. Avoid chewing gum or tough foods, which overwork jaw muscles. A custom-fitted night guard, prescribed by a dentist, is the gold standard for protecting teeth and reducing grinding force. Over-the-counter guards are less effective and may misalign the bite, so invest in a professional fitting. Regular dental checkups every 6 months catch early damage, as diabetic patients are also prone to gum disease, which bruxism exacerbates. If neuropathy is suspected, nerve conduction studies or autonomic function tests can confirm its role. Medications like clonazepam are rarely used due to dependency risks. I advocate non-pharmacological approaches first. Addressing glucose control, stress, and dental health typically resolves bruxism, restoring restful sleep and oral health. 13. Heart palpitations, the irregular drumbeat. Palpitations, linked to glucose fluctuations or electrolyte imbalances, cause a racing or irregular heartbeat. Check glucose before bed, eat a protein or carb snack, increase magnesium or potassium intake, and consult a doctor for persistent symptoms. Heart palpitations, feeling your heart race, skip, or pound, can be terrifying, especially at night when they jolt you awake. In diabetes, they often stem from glucose swings or electrolyte imbalances. Hypoglycemia triggers adrenaline, accelerating heart rate, while hyperglycemia increases sympathetic activity, causing arrhythmias. Electrolyte disruptions, particularly low potassium or magnesium, alter cardiac electrical activity, leading to premature ventricular contractions, PVCs, or atrial fibrillation. Diabetic cardiomyopathy, a lesser-known complication, also contributes. Chronic hyperglycemia stiffens heart muscle, impairing contractility and increasing arrhythmia risk. Autonomic neuropathy disrupts heart rate variability, making the heart hypersensitive to stress. In my practice, I've seen palpitations as an early clue to cardiovascular strain, particularly in patients with HbA1c above 8%. Prevention starts with glucose stability. A CGM can detect nighttime swings, guiding pre-bedtime snacks, e.g., whole grain crackers with hummus, to maintain glucose at 90 to 130 mg dl. Electrolyte balance is critical. Aim for 4,700 mg potassium, avocados, sweet potatoes, and 300 to 400 mg magnesium, nuts, seeds, daily. Avoid excessive sodium, which disrupts potassium balance. Lifestyle matters. Caffeine, alcohol, and dehydration are arrhythmia triggers, so limit these, especially in the evening. Stress reduction through mindfulness or gentle stretching lowers sympathetic tone, stabilizing heart rhythm. Exercise, 30 minutes most days, strengthens the heart but avoid intense workouts close to bedtime. If palpitations persist, an ECG or Holter monitor can diagnose arrhythmias, while blood tests check electrolytes and thyroid function. Hypothyroidism mimics palpitations. Beta blockers, e.g., metoprolol, or antiarrhythmics may be prescribed, but I prioritize addressing glucose and electrolytes first. Regular cardiovascular screenings every 1 to 2 years are essential for diabetic patients to catch early heart changes.
12. High blood pressure at night. The silent thief. High blood pressure at night, linked to autonomic neuropathy or glucose fluctuations, disrupts sleep and increases cardiovascular risks. Monitor with an automatic BP device, reduce salt, avoid caffeine, and consult a doctor for persistent issues. Normally, blood pressure dips 10-20% at night, nocturnal dipping, allowing the cardiovascular system to rest. In diabetes, this pattern is often disrupted, a phenomenon called non-dipping or reverse dipping, where blood pressure remains high or rises. Autonomic neuropathy impairs the baroreceptors that regulate blood pressure, while glucose fluctuations, particularly hypoglycemia, trigger adrenaline surges, spiking pressure. Up to 50% of diabetic patients exhibit non-dipping, doubling their risk of stroke, heart attack, or kidney failure. In my practice, nighttime hypertension is a red flag for systemic stress. Chronic hyperglycemia promotes vascular stiffness and endothelial dysfunction, narrowing arteries and elevating pressure. Sleep apnea, common in diabetes, also contributes by causing hypoxia-induced vasoconstriction. Left unchecked, this strains the heart and kidneys, accelerating complications like left ventricular hypertrophy or diabetic nephropathy. Home monitoring is essential. Use a validated automatic BP monitor, for example, Omron, to check pressure before bed and upon waking. Aim for readings below 130/80 mmHg as per American Heart Association guidelines for diabetes. Log results to identify patterns, sharing them with your doctor. Dietary sodium restriction, 1,500–2,300 mg daily, is critical as excess salt retains fluid, raising pressure. Avoid processed foods, canned soups, deli meats, and season with herbs or lemon instead. Potassium-rich foods, bananas, spinach, counteract sodium's effects, promoting vasodilation. Magnesium, 200–400 milligrams daily, also supports vascular health. Lifestyle tweaks make a difference. Avoid caffeine or alcohol 6 hours before bed, as they constrict blood vessels. Stress management through yoga, deep breathing, or Tai Chi lowers sympathetic nervous system activity, reducing pressure spikes. If sleep apnea is suspected, a sleep study is warranted, as CPAP can lower nighttime BP by 5–10 mmHg. Medications like ACE inhibitors, lisinopril, or ARBs, losartan, often taken at night, can restore dipping patterns, but timing and dosing require medical guidance. Tight glucose control, HbA1c 7%, mitigates autonomic damage, while regular exercise, 150 minutes weekly, improves vascular elasticity. Addressing nighttime hypertension is a critical step in safeguarding long-term health. 11. Nightmares or vivid dreams, the mind's nightly thriller. Low or high blood sugar overstimulates the brain, causing vivid nightmares. Sleep apnea can also trigger dreams due to oxygen deprivation. Relax before bed, reading, meditation, avoid stimulants, and consult a doctor for sleep studies or medication adjustments if severe. Nightmares and vivid dreams in diabetes are neurological distress signals, often triggered by glucose extremes. Hypoglycemia deprives the brain of glucose, its primary fuel, causing hyperarousal and intense dreams, sometimes involving fear or escape scenarios. Hyperglycemia, conversely, increases neural excitability, disrupting REM sleep and amplifying dream vividness. Sleep apnea, common in diabetes, exacerbates this by causing intermittent hypoxia, which stresses the amygdala, the brain's fear center. In my research, patients with unstable glucose often report dreams so vivid they wake up exhausted, mistaking them for reality. This isn't just disruptive, it signals poor sleep quality, which impairs glucose regulation, creating a feedback loop. Chronic sleep disruption also elevates cortisol, worsening insulin resistance and increasing HbA1c by 0.51%. Prevention hinges on glucose stability. A CGM is invaluable, alerting you to nighttime swings. A pre-bedtime snack with 10–15 grams of complex carbs, for example, quinoa with yogurt, prevents lows, while avoiding heavy meals or alcohol reduces highs. A consistent sleep schedule, 7–8 hours nightly, stabilizes REM cycles, reducing dream intensity. Relaxation is critical. High stress amplifies neural excitability, so I recommend 10–15 minutes of mindfulness meditation or journaling before bed to offload anxiety. Avoid stimulants like caffeine or nicotine, which disrupt REM sleep. Blue light from screens also suppresses melatonin, intensifying dream soothes, a blue light filter, or read a physical book instead. If nightmares persist, a sleep study can diagnose apnea or parasomnias. Adjusting diabetes medications, for example, reducing evening insulin doses, may stabilize glucose. In severe cases, low-dose prazosin, a blood pressure medication, can reduce nightmare frequency in PTSD-like scenarios, but this requires specialist oversight. Addressing glucose control and sleep hygiene typically resolves most cases, restoring peaceful nights. 10. Acid reflux, the smoldering nighttime flame. Acid reflux, caused by autonomic neuropathy slowing stomach emptying, increases esophageal pressure. Avoid trigger foods, fatty, spicy, caffeine. Eat 2–3 hours before bed, elevate the bedhead, and consult a doctor for PPIs or gastric function tests if severe. Gastroesophageal reflux disease, GERD, is a fiery torment for diabetic patients, driven by autonomic neuropathy's disruption of gastric motility. In diabetes, the vagus nerve, which controls stomach contractions, becomes impaired, delaying gastric emptying gastroparesis. This causes food to linger, increasing pressure on the lower esophageal sphincter, LES, allowing acid to reflux. Up to 40% of diabetic patients experience GERD, compared to 20% of the general population, highlighting its metabolic roots. GERD isn't just uncomfortable, it disrupts glucose absorption, as delayed gastric emptying alters insulin timing. It also increases risks of esophageal erosions or Barrett's esophagus, a precancerous condition. Nighttime symptoms are particularly severe because lying flat allows acid to pool in the esophagus, prolonging exposure. Dietary discipline is critical. Avoid trigger foods like fried dishes, tomatoes, chocolate, and alcohol, which relax the LES. Smaller, frequent meals, 4-5 daily, reduce gastric pressure compared to large meals. High-fiber foods, broccoli, oats, promote digestion, but avoid overeating fiber at night, as it can slow gastric emptying further. Positional therapy is effective. Elevating the bedhead 15-20 centimeters, using blocks, not pillows, leverages gravity to keep acid down. Sleeping on the left side aligns the stomach's natural curvature, reducing reflux risk. Weight loss, even 5-10 kilograms, significantly lowers intra-abdominal pressure, strengthening the LES. Stress exacerbates GERD by increasing acid production. Mindfulness or yoga before bed can calm the vagus nerve, improving motility. Over-the-counter antacids, for example, Tums, provide quick relief, but proton pump inhibitors, PPIs, like omeprazole, are more effective for chronic GERD. Long-term PPI use, however, risks nutrient deficiencies, B12, magnesium, so I recommend periodic reassessment. If symptoms persist, an endoscopy can assess esophageal damage, while gastric emptying studies confirm gastroparesis. Prokinetic agents like metoclopramide may improve motility but carry neurological side effects, so discuss risks with your doctor. Tight glucose control, HbA1c 7%, slows neuropathy progression, reducing GERD's root cause.
9. Insomnia, the nightly battle for sleep. Unstable blood sugar causes stress hormones to keep you awake, while poor sleep worsens insulin resistance. Maintain a consistent sleep schedule, eat a complex carb snack, avoid screens before bed, and consider melatonin or sleep studies if issues persist. Insomnia in diabetes is a vicious cycle, where poor sleep and poor glucose control feed each other. Hyperglycemia or hypoglycemia disrupts sleep by triggering cortisol and adrenaline, which heighten alertness. Conversely, sleep deprivation reduces insulin sensitivity by 20 to 30%, elevating glucose and cortisol further. This bidirectional relationship explains why diabetic patients with insomnia often struggle with HbA1c above 8%. In my research, I've noted that sleep architecture, particularly REM and deep sleep, is altered in diabetes. High glucose suppresses slow-wave sleep, critical for physical restoration, while hypoglycemia fragments REM sleep, impairing cognitive function. Over time, chronic insomnia increases risks of depression, anxiety, and cardiovascular disease, all amplified in diabetes. A consistent sleep routine is the foundation. Go to bed and wake up at the same time daily, even on weekends, to stabilize your circadian rhythm. A pre-bedtime snack with complex carbs and protein, e.g., oatmeal with walnuts, prevents glucose fluctuations. Avoid high-fat or sugary foods, which delay gastric emptying or cause spikes. Screen time is a major culprit. Blue light from phones or tablets suppresses melatonin, delaying sleep onset. I recommend a digital curfew 1 to 2 hours before bed, using blue light blocking glasses if necessary. Create a sleep-conducive environment. Keep the bedroom dark, quiet, and cool, 16 to 18 degrees Celsius, and invest in a supportive mattress. Relaxation techniques like progressive muscle relaxation or guided imagery can lower cortisol, easing you into sleep. Melatonin supplements, 1 to 5 milligrams, taken 30 minutes before bed, can help, particularly for older adults with reduced natural production, but long-term use requires medical oversight. If insomnia persists, a sleep study can diagnose underlying issues like OSA or periodic limb movement disorder, both common in diabetes. Cognitive behavioral therapy for insomnia, CBTI, is highly effective, reducing sleep onset time by 50% in trials. Medications like zolpidem are last resort due to dependency risks. Tight glucose control, supported by CGM and dietary discipline, remains the cornerstone for breaking the insomnia diabetes cycle. Nighttime hypoglycemia is a stealthy threat, striking when patients are most vulnerable, unconscious and unable to respond. Blood glucose below 70 mg per deciliter triggers counterregulatory hormones, adrenaline, glucagon, cortisol, which attempt to restore glucose by mobilizing liver glycogen. Symptoms like sweating, shakiness, or vivid nightmares are the body's desperate SOS, but severe episodes can lead to seizures, loss of consciousness, or, rarely, death. In diabetes, hypoglycemia often results from excessive insulin or sulfonylureas, mismatched with food intake or exercise. Nighttime episodes are particularly common in type 1 diabetes but also occur in type 2 patients on insulin. In my practice, I've seen patients wake up drenched in sweat or disoriented, unaware their glucose dipped below 50 mg per deciliter. CGM has revolutionized prevention, providing real-time alerts and trend data. Devices like the Guardian Connect can predict hypoglycemia 30 minutes in advance, giving patients time to act. Prevention starts with pre-bedtime planning. A glucose reading of 90 to 130 mg DL is ideal, but if below 100 mg per deciliter, a snack with 15 to 20 grams of complex carbs and 5 to 10 grams of protein, e.g., apple slices with almond butter, ensures steady glucose release. Avoid simple sugars like juice, which cause rapid spikes and crashes. Medication adjustments are critical. Long-acting insulins like degludec offer smoother overnight coverage than older insulins like NPH, reducing hypoglycemia risk. For sulfonylureas, evening doses may need reduction if nocturnal lows occur. Always coordinate with your endocrinologist, as overcorrections can lead to hypoglycemia. Lifestyle factors play a role. Evening exercise, while beneficial, can lower glucose for 12 to 24 hours, so monitor closely after workouts. Alcohol, even in moderation, inhibits gluconeogenesis, increasing hypoglycemia risk. Avoid drinking within 4 hours of bedtime. Stress management is equally important, as cortisol fluctuations can mask or mimic hypoglycemic symptoms. If hypoglycemia occurs, follow the 15 to 15 rule. Consume 15 grams of fast-acting carbs, glucose tablets, honey, wait 15 minutes, and recheck glucose. If still below 70 mg per deciliter, repeat. For severe episodes, glucagon kits, nasal or injectable, are lifesavers. Ensure family members know how to use them. Regular CGM use, paired with tight glucose control, can minimize nighttime lows, preserving both sleep and safety. 7. Foot pain or numbness, the silent electric shock. Foot pain, tingling, or numbness indicates peripheral neuropathy from prolonged high blood sugar damaging nerves. This increases injury risk, e.g., foot ulcers. Exercise, walking, yoga. Check feet daily for cuts/infections, wear comfortable shoes, and consult a doctor for persistent symptoms. Peripheral neuropathy is a hallmark of diabetes, affecting up to 50% of patients within 10 years of diagnosis. It manifests as burning, tingling, or numbness in the feet, often worsening at night when distractions are minimal. And sensory, nerves amplify discomfort. Chronic hyperglycemia damages nerve myelin sheaths and axons, impairing signal transmission. This not only causes pain but also reduces sensation, making patients prone to unnoticed injuries like cuts or blisters, which can escalate to ulcers or amputations if infected. In my research, I've seen neuropathy's insidious progression. Early tingling can evolve into complete sensory loss, particularly in the distal extremities. Nighttime exacerbation occurs because the body's circadian rhythm lowers pain thresholds during rest, and reduced blood flow in a supine position amplifies ischemic nerve pain. Vascular insufficiency, common in diabetes, further starves nerves of oxygen, worsening symptoms. Management requires a proactive, multifaceted approach. Exercise is critical. 30 minutes of daily walking or low-impact aerobics improves circulation and nerve health. Yoga poses like tree pose or warrior two enhance balance, reducing fall risk in patients with sensory loss. However, avoid high-impact activities that stress neuropathic feet. Foot care is non-negotiable. Inspect feet daily using a mirror or ask a family member for help, checking for cuts, redness, or swelling. Moisturize to prevent cracks, but avoid applying lotion between toes to reduce infection risk. Custom orthotics or diabetic shoes with wide toe boxes minimize pressure points. Nutrition supports nerve repair. Alpha-lipoic acid, 600 to 1,200 milligrams daily, an antioxidant, has shown promise in reducing neuropathic pain in clinical trials, but consult your doctor for dosing. B vitamins, particularly B1, thiamine, and B12, are essential for nerve health. Diabetic patients are often deficient due to metformin use or poor absorption. Foods like eggs, salmon, and fortified cereals are excellent sources. Tight glucose control, HbA1c less than 7%, is the cornerstone as it slows nerve damage progression. Medications like duloxetine or pregabalin can alleviate pain, but I prioritize lifestyle and glucose management to address the root cause. If symptoms worsen, nerve conduction studies or skin biopsies can quantify neuropathy severity, guiding treatment. Podiatric consultations every 6 to 12 months are essential to prevent complications. 6. Excessive thirst, an unquenchable urge. Persistent thirst, especially at night, signals high blood sugar, as kidneys excrete excess glucose, causing dehydration. This can lead to electrolyte imbalances. Stay hydrated throughout the day, avoid overdrinking at once, and consult a doctor if thirst persists with symptoms like dry mouth or fatigue. Excessive thirst, polydipsia, is a classic diabetes symptom, yet its nighttime prominence is often underappreciated. When blood glucose exceeds the renal threshold, around 180 milligrams per deciliter, the kidneys excrete glucose, drawing water along, leading to dehydration. This triggers the brain's thirst center, creating an insatiable urge to drink. In diabetes, this cycle is relentless, as poor glucose control perpetuates the loop of urination and thirst. Dehydration from polydipsia isn't just about water loss. It disrupts electrolyte balance, particularly sodium and potassium, which can cause muscle weakness, cramps, or even cardiac arrhythmias in severe cases. Chronic dehydration also stresses the kidneys, accelerating damage in diabetic nephropathy. In my clinical observations, patients with undiagnosed or poorly managed type 2 diabetes often report waking up parched, sometimes drinking 1 to 2 liters overnight, only to urinate it out. Hydration strategy is key. Aim for 2 to 3 liters of water daily, sipped consistently rather than gulped, to maintain steady hydration without overwhelming the kidneys. Electrolyte-enhanced water, low sugar, like Pedialyte, can help, but avoid sugary sports drinks that spike glucose. Herbal teas like chamomile or peppermint can hydrate while calming the nervous system, aiding sleep. Glycemic control is the ultimate solution. Metformin, GLP-1 agonists, e.g., liraglutide, or insulin therapy, tailored to your needs, can lower glucose below the renal threshold, reducing thirst. Monitor fasting and postprandial glucose to identify patterns triggering polydipsia. A CGM can provide real-time insights, especially for nighttime spikes. Lifestyle factors matter. Stress and poor sleep elevate cortisol, worsening hyperglycemia and thirst. Incorporate relaxation techniques like diaphragmatic breathing or mindfulness meditation before bed. If thirst persists despite glucose control, consider other causes like Sjogren's syndrome, an autoimmune condition causing dry mouth, or medications, e.g., diuretics. Blood tests for sodium, potassium, and kidney function can uncover hidden issues. 5. Frequent nighttime urination. Nocturia, the endless bathroom trips. High blood sugar forces kidneys to filter excess glucose, increasing urine production and nighttime urination. This disrupts sleep and risks dehydration or electrolyte imbalances. Limit fluid intake 2 to 3 hours before bed, avoid caffeine/alcohol, and consult a doctor for kidney/bladder evaluation if symptoms persist. Nocturia is more than a nuisance, it's a metabolic alarm bell. In diabetes, hyperglycemia overwhelms the kidney's ability to reabsorb glucose, leading to osmotic diuresis. Essentially, glucose pulls water into the urine, increasing volume and frequency. This can result in 3 to 4 bathroom trips per night, fragmenting sleep and causing daytime fatigue. Over time, chronic nocturia risks dehydration, as the body loses water faster than it's replenished, and electrolyte imbalances, particularly sodium and potassium, which can trigger cramps or arrhythmias. Diabetic nephropathy, affecting 20 to 40% of patients, is a deeper concern. Damaged kidneys lose their ability to concentrate urine, exacerbating nocturia. In my research, I've seen nocturia often precede proteinuria, protein in urine, an early marker of kidney damage. Bladder dysfunction, driven by autonomic neuropathy, can also contribute, as the bladder becomes overactive or fails to empty fully, leading to frequent urges. To manage nocturia, timing is everything. Hydrate aggressively during the day, 1.5 to 2 liters, adjusted for body weight, but reduce intake after 6 p.m. to minimize bladder filling overnight. Avoid diuretics like caffeine, alcohol, and high-sugar drinks, which amplify urine production. A balanced diet low in sodium, under 2,300 milligrams daily, can reduce fluid retention, easing kidney workload. Glycemic control is paramount. Keeping fasting glucose below 130 milligrams per deciliter and HbA1c under 7% reduces osmotic diuresis. SGLT2 inhibitors, e.g., empagliflozin, can paradoxically increase urination initially, but improve glucose control long-term, reducing nocturia. However, discuss risks like urinary infections with your doctor. Pelvic floor exercises, Kegels, 10 to 15 reps thrice daily, strengthen bladder muscles, improving control. For men, nocturia may signal benign prostatic hyperplasia, BPH. Common in older diabetic patients, so a prostate exam may be warranted. If nocturia persists, request a renal function panel, creatinine, eGFR, and urinalysis to rule out nephropathy or infections. In severe cases, medications like desmopressin may reduce nighttime urine production, but these require careful monitoring to avoid hyponatremia. 4. Sleep apnea, the breath-stealing intruder. Sleep apnea interrupts breathing, causing oxygen deprivation and frequent awakenings. It's linked to insulin resistance, worsening diabetes control, and increasing cardiovascular risks. Monitor symptoms like loud snoring or gasping, lose weight if overweight, avoid alcohol/sedatives, and consult a doctor for sleep studies if needed. Obstructive sleep apnea, OSA, is a silent saboteur, particularly for diabetic patients, where its prevalence can reach 30 to 50% compared to 5 to 10% in the general population. OSA occurs when the upper airway collapses during sleep, blocking airflow and causing repeated pauses in breathing. Each pause, apnea, starves the brain and body of oxygen, triggering a stress response that spikes adrenaline and cortisol. These hormones not only disrupt sleep, but also elevate blood glucose by promoting glycogenolysis and gluconeogenesis, making diabetes management a Sisyphean task. The link between OSA and insulin resistance is particularly concerning. Hypoxia, low oxygen, and sleep fragmentation impair glucose metabolism, reducing insulin sensitivity by up to 25% in some studies. This creates a vicious cycle. Poor glucose control worsens OSA by promoting inflammation and fat deposition in the airway, while OSA exacerbates hyperglycemia. Over time, this duo amplifies cardiovascular risks, with OSA patients facing a 2 to 3 times higher likelihood of hypertension, stroke, or heart attack. In my experience, patients often underestimate OSA because snoring is normalized or dismissed as a quirk. However, signs like daytime fatigue, morning headaches, or gasping awake are red flags. Weight management is critical, as excess fat around the neck narrows the airway. Even a 5 to 10% weight loss can reduce OSA severity by 20 to 30%. I advocate a Mediterranean-style diet rich in vegetables, lean proteins, and healthy fats to support weight loss and reduce inflammation. Positional therapy, sleeping on your side rather than your back, can help, as gravity is less likely to collapse the airway. Avoid alcohol and sedatives, which relax throat muscles excessively. For moderate to severe OSA, continuous positive airway pressure, CPAP. Therapy is a game changer. CPAP delivers pressurized air to keep the airway open, improving sleep quality and glucose control. Studies show CPAP users can lower HbA1c by 0.5 to 1% over 3 to 6 months. Early diagnosis is crucial. A home sleep apnea test or polysomnography sleep study can confirm OSA and guide treatment. If left untreated, OSA accelerates diabetic complications like retinopathy and nephropathy by promoting oxidative stress and endothelial dysfunction. Dental appliances or surgical options may be considered for CPAP-intolerant patients, but I emphasize lifestyle changes as the foundation for long-term success. 3. Restless leg syndrome. RLS, the unstoppable urge to move. RLS causes an irresistible urge to move the legs, often with tingling or burning sensations, disrupting sleep. It's linked to peripheral neuropathy and dopamine imbalances, both tied to diabetes. To manage, exercise lightly, walking, stretching, increase iron and magnesium intake, leafy greens, nuts, and avoid caffeine/nicotine in the evening. Restless leg syndrome, RLS, is a neurological condition that transforms bedtime into a battleground. For diabetic patients, it's a double-edged sword, driven by both peripheral neuropathy and metabolic disruptions. The hallmark of RLS, an overwhelming urge to move the legs, often accompanied by crawling or prickling sensations, stems from dysfunctional nerve signaling. In diabetes, chronic hyperglycemia damages peripheral nerves, particularly in the legs, causing them to misfire. This creates a feedback loop where the brain interprets these signals as discomfort, prompting constant movement. Dopamine dysregulation is another key player. Dopamine, a neurotransmitter, regulates muscle movement and sensory processing. Diabetes can impair dopamine synthesis indirectly by disrupting metabolic pathways, particularly in the brain's basal ganglia. Research suggests that up to 20% of diabetic patients experience RLS, a prevalence far higher than in the general population, underscoring its metabolic roots. Iron deficiency, often overlooked, is a critical cofactor. Iron is essential for dopamine production, and diabetes can impair iron absorption or increase its excretion through frequent urination. In my practice, I've seen patients with borderline ferritin levels below 50 nanograms per milliliter experience significant RLS relief with supplementation, though this must be guided by blood tests to avoid overload. Lifestyle interventions are the cornerstone of RLS management. Light exercise, such as 15 to 20 minutes of walking or yoga in the early evening, can calm overactive nerves and improve circulation. Avoid intense workouts close to bedtime, as they can exacerbate symptoms. Stretching routines targeting the calves and hamstrings, held for 20 to 30 seconds per muscle group, can reduce nighttime restlessness. Dietary adjustments are equally vital. Magnesium-rich foods, almonds, pumpkin seeds, spinach, support nerve health, while iron-rich options, red meat, lentils, fortified cereals, address deficiencies. Pair iron-rich meals with vitamin C sources, bell peppers, citrus, to enhance absorption, but avoid calcium-rich foods at the same meal, as they inhibit iron uptake. Environmental and behavioral tweaks can amplify relief. Caffeine and nicotine are notorious RLS triggers, as they stimulate the central nervous system. I advise patients to cut off caffeine by noon and avoid nicotine entirely, as even secondhand smoke can worsen symptoms. A warm bath or a leg massage before bed can soothe nerves and promote relaxation, while compression socks, 15 to 20 millimeters of mercury, may improve circulation and reduce discomfort. For persistent RLS, medical evaluation is essential. Blood tests for ferritin, hemoglobin A1c, and kidney function can pinpoint underlying issues. In severe cases, medications like dopamine agonists, ropinirole, pramipexole, or alpha-2 delta ligands gabapentin may be considered, but I caution against over-reliance, as they carry risks like augmentation, worsening symptoms over time. Tight glucose control remains the foundation, as it slows neuropathy progression and stabilizes dopamine pathways. 2. Leg cramps, a painful pinch in the night. Leg cramps may result from electrolyte imbalances, potassium, magnesium, calcium deficiencies, or peripheral neuropathy, causing painful muscle contractions. Poor blood circulation, common in diabetes, can also trigger cramps. To reduce risk, consume potassium-rich foods, bananas, sweet potatoes. Magnesium-rich foods, leafy greens, nuts, and perform calf stretches before bed. Consult a doctor for frequent cramps to assess nerve or vascular function. Leg cramps are a distressing symptom that can jolt you awake, leaving you sore and sleep-deprived. In the context of diabetes, they're often a multifaceted issue involving metabolic, neurological, and vascular components. Electrolyte imbalances are a key culprit. Diabetes, particularly when poorly controlled, can lead to excessive urination, polyuria, which flushes out essential minerals like potassium, magnesium, and calcium. These minerals are critical for muscle relaxation and contraction. For instance, magnesium acts as a natural calcium channel blocker, preventing excessive muscle firing. When levels drop, muscles can contract uncontrollably, resulting in cramps. Peripheral neuropathy, affecting up to 60% of diabetic patients over time, is another major factor. Damaged nerves misfire, sending erratic signals to muscles, which respond with painful spasms. In my research, I've observed that cramps often precede other neuropathic symptoms, serving as an early warning of nerve damage. Poor circulation, driven by diabetic vasculopathy, compounds the problem. Narrowed arteries reduce oxygen delivery to muscles, triggering cramps, especially at night when blood flow naturally slows during inactivity. To address leg cramps holistically, start with nutrition. Potassium-rich foods like avocados, spinach, and oranges are excellent choices, but be mindful of portion sizes to avoid glucose spikes. Magnesium supplementation, 200 to 400 milligrams daily, preferably as magnesium citrate or glycinate, can be transformative, but consult your doctor to avoid interactions with medications. Calcium intake, often overlooked, is equally important. Aim for 1,000 to 1,200 milligrams daily through dairy, fortified plant milks, or supplements if needed. Physical activity is non-negotiable. Sedentary lifestyles exacerbate circulation issues, so I recommend low-impact exercises like walking 20 to 30 minutes daily or yoga poses like downward dog to enhance blood flow to the legs. Before bed, try a structured stretching routine. Hold a calf stretch for 30 seconds per leg, repeating 2 to 3 times. Foam rolling can also release muscle tension and improve circulation. Hydration is critical, as dehydration concentrates electrolytes, increasing cramp risk. Aim for balanced fluid intake throughout the day, but avoid excessive water, which can dilute sodium levels. For patients with frequent cramps, I often suggest electrolyte-enhanced drinks, low-sugar options like coconut water, in moderation. If cramps persist, don't delay medical evaluation. A Doppler ultrasound can assess blood flow, while electromyography, EMG, or nerve conduction studies can confirm neuropathy. In some cases, medications like gabapentin or pregabalin may be prescribed to calm overactive nerves, though I advocate addressing root causes like glucose control first. Tight glycemic management, HbA1c less than 7%, can slow neuropathy progression and reduce cramp frequency over time. 1. Night sweats, a silent storm while you sleep. Night sweats can signal low blood sugar, hypoglycemia, triggering adrenaline release that increases heart rate and activates sweat glands. This may also stem from diabetic neuropathy, where damaged nerves disrupt sweat gland regulation. Monitor blood sugar before bed. Target 90 to 130 mg/dl. Eat a low glycemic snack, e.g., whole grain bread with peanut butter. Keep room temperature at 64 to 70 degrees Fahrenheit, 18 to 21 degrees Celsius, and consult a doctor for persistent issues, possibly for HbA1c or nerve function tests. Night sweats are far more than an inconvenience. They are a window into the complex interplay of your body's metabolic and neurological systems. As a seasoned medical researcher, I've seen how patients often dismiss night sweats as a byproduct of a warm room or stress, but in the context of diabetes, they can be a critical warning. Hypoglycemia at night is particularly insidious because it occurs when you're least aware, during sleep. The body, sensing a drop in glucose, unleashes a cascade of stress hormones like adrenaline and cortisol. These hormones not only stimulate sweating but also put strain on your cardiovascular system, potentially increasing the risk of heart palpitations or even arrhythmias over time. From a neurological perspective, diabetic neuropathy, a common complication affecting up to 50% of diabetic patients, can disrupt the autonomic nervous system's control over sweat glands. This damage isn't just about sweating. It's a sign that other autonomic functions, like heart rate regulation or digestion, might also be compromised. Over my years of research, I've noted that patients with early neuropathy often report night sweats before other symptoms like numbness or tingling become apparent, making this a potential early diagnostic clue. To manage night sweats effectively, I recommend a multi-pronged approach beyond the basics. First, consider the timing of your meals and medications. Taking insulin or sulfonylureas too close to bedtime can precipitate nocturnal hypoglycemia. Work with your endocrinologist to adjust dosing schedules, potentially shifting to long-acting insulin analogs that provide steadier glucose control overnight. Second, incorporate stress-reducing practices before bed. Chronic stress elevates cortisol, which can exacerbate glucose fluctuations. Techniques like progressive muscle relaxation or guided meditation can lower cortisol levels, reducing the likelihood of night sweats. Diet plays a pivotal role as well. While a low glycemic snack is helpful, I advise patients to experiment with combinations that balance protein, healthy fats, and complex carbohydrates. For example, a small serving of Greek yogurt with chia seeds and a few almonds provides sustained glucose release without spiking blood sugar. Hydration is equally critical. Dehydration from excessive sweating can further destabilize electrolytes, compounding symptoms. Aim for 8 to 10 glasses of water daily, but taper off intake 2 to 3 hours before bed to avoid disrupting sleep with bathroom trips. Environmental factors shouldn't be overlooked. The recommended room temperature of 18 to 21 degrees Celsius is ideal because it aligns with the body's natural thermoregulatory needs during sleep. However, I've found that patients with diabetes may benefit from slightly cooler settings, around 17 degrees Celsius, if neuropathy impairs their ability to regulate body temperature. Use breathable, moisture-wicking bedding materials like bamboo or cotton to enhance comfort. Finally, don't underestimate the value of continuous glucose monitoring, CGM. Devices like the Dexcom G7 or Freestyle Libre can alert you to hypoglycemia in real time, allowing you to intervene before night sweats disrupt your sleep. In my practice, I've seen CGM transform patients' lives by providing peace of mind and actionable data. If night sweats persist despite these measures, consult a specialist. Tests like HbA1c provide a snapshot of your average blood sugar over 3 months, but I also recommend nerve conduction studies or autonomic function tests to assess neuropathy's extent. Early intervention can prevent progression to more severe complications like gastroparesis or cardiovascular autonomic neuropathy. These 15 nighttime symptoms are your body's way of whispering warnings about diabetes before they become screams. From night sweats to morning headaches, each sign is a clue to underlying metabolic, neurological, or vascular issues. By addressing them early, through tight glucose control, lifestyle changes, and medical intervention, you can prevent complications and reclaim restful nights. Subscribe to Golden Years Health 2025 for more expert insights, and share this video with anyone who needs to hear it. Let's take charge of our health, one night at a time.